Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features expert insight from a webinar titled Clinical Impact of New Data on Complicated Clinical Infections, Independent Conference Coverage of ECCMID 2023, featuring Dr. David Van Duin, Professor of Medicine and Director of Immunocompromised Host Infectious Diseases Program at the University of North Carolina in Chapel Hill. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Van Duin has to say about new data on complicated clinical infections from ECCMID 2023.
Hi, everyone, and thank you for joining, and thank you for that excellent introduction. So we'll start with a couple of sessions that I wanted to highlight on gram-negative resistance. The first one covered KPC producers, or Klebsiella pneumoniae carbapenem-resistant, and it looked specifically at a newer drug, meropenem-vaborbactam, in KPC-producing carbapenem-resistant Enterobacterales infections. And on this slide, you can see their study design, and this was a real-world study looking at the use of meropenem-vaborbactam in the US. And what was nice here is that they were able to get some PK data as well on a subset of these patients. So they had 37 patients, so a relatively small sample size. As you can see, a fair number of these patients were transplant recipients. They had a Charlson and an Apache score that indicated that both chronic comorbidities as well as acute comorbidities that were present. And treatment was often initiated in the ICU, again, sort of a testament to the illness of the patients that were involved. About a third of the patients were on renal replacement therapy. And then there was a predominance of the use of monotherapy, so without any other active agents. And when you look at the KPC type, as we've seen in other studies from the US at least, KPC2 and KPC3 were the most common carbapenem-resistant. So then when we look at the outcomes, they had clinical success at day 30 in 68% of these patients. Microbiological failure at day 90 was seen in 11 patients with a median time to failure of 38 days. And in 8 of these 11 patients, this was deemed to be either a persistent or recurrent infection, whereas in 3, this was just thought to be colonization. And this was something that was really interesting about this study, is that they looked at subsequent CRE isolates, which were present in 15 patients, one of whom developed treatment-emergent resistant to meropenem-vaborbactam. 2 other patients did have a quite significant MIC increase, but it stayed within the realm of susceptibility for those isolates. And some of the reasons for clinical failure were death in 6 patients, lack of clinical improvement in 3 patients, recurrent infection in 2, and persistent bacteremia in 1. So then switching to the pharmacokinetic results, they had 96 samples from 21 patients, and they used 17 patients who had at least 3 samples to determine the PK parameters. And they had serial blood cultures at 3 different time periods, with 5, 7, and 8 as the later trough time periods. And what was quite nice about the study was that they had different renal function groups, again, this being a real-world study, and the patients that this drug is being used in being quite ill. So you really want to make sure that in a variety of settings of renal failure, how the drug performs. So they did see significant interpatient variability of meropenem, as has also been described in other studies, but the exposures exceeded target of 100% time over MIC and 100% time over 4 times the MIC in all patients. And for vaborbactam, they were looking at the area under the curve over MIC as the target, and this was also exceeded in all patients. So the peaky target exposures were met for both meropenem and vaborbactam. So moving on to our next topic, carbapenem-resistant Acinetobacter baumannii. And this was a real-world observational follow-up to the credible CR study. So in the credible CR study, there were higher mortality rates observed in patients getting cefiderocol versus best available therapy for Acinetobacter infections. And so what they did here was they had a single center observational study with a relatively small sample size of 73 patients who were all in the COVID ICU with ventilator-associated pneumonia and also concomitant bloodstream infection caused by Acinetobacter. Colistin-containing regimens were used in most of the patients in 74%, and then cefiderocol-containing regimens were used in 19 patients, and all of those got some sort of a combination therapy. So they wanted to specifically see how does cefiderocol do when used in combination. Can we get some sort of indication from this observational data set? As you can see, a lot of patients were quite ill, with 67% of patients developing septic shock, and there were no differences in the parameters that they looked at between the two groups. But there was a quite substantial difference in both the 14-day mortality and the 30-day mortality when patients on cefiderocol-containing regimens were compared to those on colistin-containing regimens. So, and here you see that the survival curve that goes with that, and they did some adjustment also for a variety of factors to try to get some approximation of the effect of confounding by indication. And they did this both through regression analysis and also through propensity score analysis. And with both those corrections, being on a cefiderocol-containing regimen, and especially being on the regimen of cefiderocol plus phosphomycin, was associated with improved survival. Moving on to Pseudomonas, and this was another real-world study looking at the use of imipenem relebactam. And this was a little bit different in design. They used this large healthcare database called the Premier database, which is a really large database that covers a large percentage of US hospitals. But of course, you're limited in the types of data that are going to be available in a database like this. So they were able to get together data on 160 patients. And when you look here at the characteristics, you can again see that similar to these other sort of ways that these other new agents are being used, that patients are quite sick. So lots of patients in the ICU, more than half of the patients on mechanical ventilation, 40% with septic shock. And then looking at the infection types for which IMI-REL was used, Hep VAP was the most common in over half of the patients, and then CUTI and intra-abdominal infections in smaller percentages. In the pathogen data was only available for 37 patients, so pretty small subset for a study that really focuses on the use of an antibiotic. And in most of those patients, Pseudomonas was the pathogen. And in about a third of patients, it was a polymicrobial infection with 2 or more pathogens present. Specific patterns of resistance, again, was mostly multidrug-resistant Pseudomonas with a few ESBL or CRE. So looking then at the treatment characteristics, so the status of the patient, again, if you looked at all patients, they were in the ICU about half the time, but in the Hep VAP group, that was higher. And again, generally speaking, the Hep VAP group was appeared to be sicker at baseline, as you would expect. It also took a longer time from admission to the start of IMI-REL in that Hep VAP group, 17 days versus 8 days. The median duration was similar in both these groups of all patients and the subset of Hep VAP patients with 7 days as a median. And you can see that the interquartile range is fairly broad between 4 and 13. Looking at the outcomes, long length of stay, 25 in the whole group and 32 days in the Hep VAP group. ICU, also a long stay in the ICU with 27 and 29 days, and also relatively high all-cause in-hospital mortality with 24 and 39%. When you look at the 30-day all-cause mortality, that was 21% and 31% in those patients with Hep VAP, who we already talked about were sicker on the onset. And also readmission rates were noted to be 17% and 9% in these two groups. So as the take-home points for these gram-negative resistance study, meropenem vaborbactam was effective in treating KPC-producing infections with optimal exposures observed in predominantly critically ill patients. In an observational study, survival benefit was seen among patients receiving cefiderocol-containing regimens as combination therapy, importantly, versus colistin-containing regimens for treatment of Acinetobacter VAP with concomitant BSI. And again, important to note here that common combination that was used with cefiderocol was fosfomycin. And then finally, little data is available on imipenem relebactam use for the treatment of MDRO infections. And the real-world data provided here gives some initial understanding of how this drug is being used in the US, that is, especially amongst patients with HAP-VAP caused by multidrug-resistant Pseudomonas. So moving on to antimicrobial stewardship. First study I want to discuss is the so-called SIMPLIFY study that looked at antibiotic de-escalation for monomicrobial Enterobacterales bloodstream infection. So this was an interesting design where they looked at patients who turned out to have monobacterial Enterobacterales bloodstream infection, but who were initially treated with an antipseudomonal beta-lactam drug. So at the time of susceptibility results, they had 48 hours to be enrolled in this study and could either be randomized to the de-escalation arm, in which they were switched to an in vitro active drug that was set by a certain list, and we'll show you what they switched to, or they were randomized to continue that antipseudomonal beta-lactam empirically. Primary outcome was clinical cure 3 to 5 days after end of treatment with a 10% non-inferiority margin. Secondary outcomes included 60-day mortality, infection recurrences, and development of CDI, so Clostridium difficile infection. They also did a desirability of outcome ranking analysis at day 60, which had as the best rank that you were cured without incidences, and the worst rank was death. So then looking at the drugs that people were switched to in the de-escalation arm, so you see them listed here: ampicillin, amoxicillin, clavulanic acid, cotrimoxazole, ceftriaxone, or cefotaxime was used in about a third, so that was the single most common one. And then ciprofloxacin and ertapenem were also used. And there was also a step down to oral therapy allowed with specific guidance given in the protocol. When you look here at the distribution both of the organisms that were involved, you can see that E. coli was by far the most common one, and also the sources of bacteremia, with biliary tract and urinary tract being most common in both treatment arms. And one thing that is a little bit different from a lot of other Enterobacterales bloodstream infection studies is this predominance of biliary tract disease, which is probably explained by the requirement that people had to be started on antipseudomonal beta-lactam. So these tended to be patients where there was a broader initial treatment. So then looking at the outcomes that they observed, so overall there was no difference between the two arms, with clinical cure being slightly in favor of the de-escalation arm, 90% versus 89%, so really pretty much essentially the same. Relapses at day 60 were also quite similar at 6% versus 11%. Death at day 60 at 5% versus 5%, so again, really identical numbers. And then Clostridioides, I should say, infection was quite uncommon and it occurred in one patient in each group. And there were also no differences seen in their DOR analyses. And it's important to note that when you do a DOR analysis, 50% is the sort of no difference mark. So switching to the next study, the so-called SOAB study that looked at a switch from IV to oral antibiotics, which of course is quite interesting because this is something that we do quite commonly already in monomicrobial Enterobacterales bloodstream infection. So it was nice that they put this in a randomized controlled trial. This was done in the Middle East. And unfortunately, this study had to be stopped early because of COVID-19 related issues. So you see here that they looked at adults with monomicrobial Enterobacterales bloodstream infection susceptible to an oral beta-lactam fluoroquinolone or trimethoprim sulfomethoxazole with adequate source control these patients had to be quite stable, so they had to have been afebrile, had to have a good blood pressure, not need any help with their blood pressure. They couldn't be neutropenic, and they had to be getting already IV therapy for 3 to 5 days. They were then randomized to switching to an oral antibiotic or to continue their IV antibiotic with a primary outcome of treatment failure, which was a composite with the components that you can see here within 90 days, and they used a 10% non-inferiority margin in the modified intention to treat population. So looking at the baseline characteristics in this study, they were pretty well matched. The Johnson comorbidity score was 3, indicating sort of a moderate chronic comorbidity load. The pit bacteremia score in both groups was quite low at 1, so that would be predictive of a lower associated mortality. And then you see the distribution of the ultimate antimicrobial that patients ended up on. So cephalosporins were used in both groups quite commonly, as were beta-lactamase inhibitor combinations. Carbapenems were obviously only used in the IV group, whereas fluoroquinolones and trimethoprim sulfamethoxazole were only used in the oral group. Urinary tract infections were the most common, as is mostly the case in these types of studies, as we've discussed already. And then of the specific Enterobacterales that were isolated, again, as is mostly the case in these types of studies, E. coli was present in about 2/3 of patients. So looking at outcomes in this study, you can see that treatment failure occurred in about 22% versus 26% in favor of the oral group, and hospital length of stay was lower in the oral group versus the IV group. So quite promising that you can see a similar treatment failure rate and a shorter hospital length of stay. One sort of side note on this, and the authors unfortunately didn't really go into this during their presentation, but when you look at the DOOR outcomes, so this again is the desirability of outcome ranking, which is an ordinal outcome, you can see that the percentage of patients in the oral group who remain on any kind of antibiotics, be it oral or IV, is in total higher at 63% versus the IV group, where it's 45%. So it seems to have resulted in longer total antibiotic treatment durations, which were at the discretion of the treating physician. Moving on to the REGARD VAP study, which was looking at whether antibiotic duration for ventilator-associated pneumonia could be further shortened. This was a trial that was done in Nepal, Thailand, and Singapore, pragmatic trial. Patients were randomized to short durations, which could mean stopping antibiotics immediately as early as day 3 if culture negative or day 5 if culture positive, versus the standard of care, which was at least 8 days and then stopping based on physician preference. So the stopping criteria was that patients had to be afebrile and otherwise hemodynamically stable. Primary outcome was mortality at day 60 or a pneumonia recurrence with a non-inferiority margin of 12%. And then some secondary outcomes are listed here as well. So looking then at the results, they found that the median antibiotic duration, as you can imagine, would be shorter in the short duration, with 6 days with an interquartile range of 5 to 7 versus 14 days in the standard of care. So pretty significant benefit, I would say. And in the day 60 outcomes, these were quite similar for the mortality outcomes. In fact, somewhat in favor of the, numerically in favor, I should say, of the shorter duration. So take home from these antimicrobial stewardship studies were that the SIMPLIFY study showed that antibiotic de-escalation from an antipseudomonal beta-lactam was non-inferior to continuing that drug. In the SOAB study, switching to oral antibiotics after an IV lead-in therapy was non-inferior to continuing IV therapy. And in the REGARD VAP study, shortened antibiotic treatment guided by clinical criteria was non-inferior to longer treatment duration. So really supportive of a lot of stewardship efforts that are already being done. So we'll switch to investigational agents. And first, I just quickly want to cover sulbactam, relebactam. The ATTACK trial was already covered at ID Week, and I'll just briefly mention this here. You can see the main results in the slide with Soldor being non-inferior to colistin in 28-day all-cause mortality, with certainly a numeric benefit of Soldor of 19% versus 32% in the colistin arm. And then what they presented here at ECCMID was in their part B of this study, there were patients enrolled who had colistin-resistant organisms or who couldn't tolerate colistin. And they looked at specific sites who had outbreaks of colistin-resistant Acinetobacter. And 19 of those patients had those colistin-resistant Acinetobacter, with all but one isolate susceptible to sulbactam relebactam, so really a promising agent for that really challenging group. 16 of these patients actually ended up getting sulbactam relebactam with an 87.5% survival at day 28. So again, a very promising result. And then lastly, I just want to cover two agents that are sort of in the pipeline. Gepotidacin was studied in the EAGLE-2 and EAGLE-3 studies, and was non-inferior to nitrofurantoin for uncomplicated cystitis, and even superior in the EAGLE-3 study with some higher rates of nausea noted with the new drug. And then in the SURE-2 study that they looked at sulipenem, and they compared it to ertapenem followed by either oral ciprofloxacin or amoxicillin clavulanate, and unfortunately found that sulipenem was not non-inferior to ertapenem. And this was driven primarily by lower rates of asymptomatic bacteriuria in those patients who received either ertapenem or ciprofloxacin. All right, then we'll get to questions and answers. And I have a number of questions here in the chat that I will start going to. So a question from Quinton is, for a ventilator-associated pneumonia caused by a carbapenem-resistant Acinetobacter baumannii with no susceptibilities showing on the micropanel, could I start a combination regimen with cefiderocol and a second agent before knowing if either agent has susceptibility? Do you have a recommendation about that second agent? So yes, so that's a great question. I don't think we really have a clear answer yet. And for the use of cefiderocol, of course, the specter in the room, the elephant in the room is still the credible CR results that really indicate there was a higher mortality in the cefiderocol treated patients. Again, these observational data seem to suggest that maybe cefiderocol in combination with a second agent is a better option. And certainly that is biologically possible. So if you have a patient who is not suitable for colistin-containing regimen, and you don't have access to other active agents like the sulbactam relebactam, it could certainly be reasonable to give a combination treatment with cefiderocol. And I would probably flip this on its head and say, if you are using cefiderocol for Acinetobacter specifically, I would add a second agent, and the choice of that second agent really depends on your local pharmacy. So do you have IV phosphomycin, or if you're in the US, then you won't have access to that drug, so you can use high-dose ampicillin sulbactam, for instance, or a number of other possible secondary agents. All right, let me go to the second question. This one is from Jacqueline. In what patients would you recommend the use of meropenem, vaborbactam, cefiderocol, or imipenem, relebactam? So yes, I think the specific niches of these drugs continues to be defined and probably will evolve over time as well. I think at the current time, especially sort of in my US-based practice, I think of meropenem, vaborbactam as primarily a CRE drug, so carbapenem-resistant Enterobacterales, and that's primarily because it performs well in the most common mechanisms of resistance, which are in the US, either no carbapenemase present or a KPC carbapenemase present. So for that, of course, you do want to know either the genotype or that there is a phenotypic susceptibility to meropenem, vaborbactam. The cefiderocol is, still sort of a more of a second line agent. It's not really a specific group of patients or organisms where cefiderocol is currently first line. We have used it some in Stenotrophomonas, of course, very limited clinical data available, but the in vitro data do support that use. And then for imipenem, relebactam, this can also be used in CRE as well as in carbapenem-resistant pseudomonas as well. Again, with the caveat that you really want to show susceptibility. So then a question from Allison: will the new study results on use of cefiderocol in Acinetobacter change the recommended use of high-dose ampicillin-sulbactam as preferred agent? So I can only really speculate, but in general, sort of a smallish observational study would not have sufficient power to really change guideline recommendations. Of course, if you're referring to the IDSA guidance recommendation, these are really, especially in Acinetobacter, where the evidence is not quite that strong, are more suggestions rather than strong recommendations as you would get from a guideline. So there may be, the addition of more of a footnote about using cefiderocol in combination therapy, but I think people still favor the use of high-dose ampicillin-sulbactam. And then, of course, the arrival of sulbactam, relebactam is quite anticipated. Another question from Jacqueline about the types of agents that you can use as a step-down for oral therapy in patients with Enterobacterales bloodstream infection. Yes, I think that the most experience certainly is with those oral agents that are known to have really good oral bioavailability. So these are going to be your fluoroquinolones, so ciprofloxacin, levofloxacin, as well as trimethoprim, sulfamethoxazole. There is some debate over the use of beta-lactams in this setting. Beta-lactams there's sometimes some concern about their effectiveness. And I think that's really an issue that's actively being studied and where people are getting more experience. But I would say it's already, even though, again, there's really to date not strong randomized controlled trial data to support this, but doing an oral step down to a quinolone or to trimethoprim sulfamethoxazole is pretty commonly done in clinical practice. Of course, a factor that complicates this is that we don't yet really know how many days is sufficient in most of these patients. So it may turn out that if you give somebody 5 days, for instance, and you give them another 2 days of an oral agent, that those 5 days of an IV may in and of itself be sufficient. All right, then I think maybe the last question from Jason is about a patient that he saw with a polymicrobial foot infection that turned out to be an osteomyelitis, so bone infection. So these infections certainly can be quite challenging. Ended up with an amputation and a PICC line infectious disease, only treated him for 11 days with IV antibiotics using the ceftriaxone. Do you think this was an appropriate length of time for the PICC line? He went on to have more osteomyelitis developed and 3 more surgeries and ended up in a below-the-knee amputation. I'm sorry to hear about this case. So in general, obviously it's hard for me to comment about a case that I know very little about. When we try to make these kind of recommendations on duration, one thing that we really try to figure out to the best of our ability is in the setting of osteomyelitis, where there is at least a partial amputation performed, it is, of course, a crucial difference whether all the infected bone has been removed at the time of amputation. If that is the case, then usually a shorter duration as sort of a skin and soft tissue type of treatment would be effective. If that's not the case, then usually a longer duration would be required. But unfortunately, sometimes you think you know, and then it turns out that you don't. The other thing I would say regarding IV treatment versus oral treatment, we do have a large randomized trial that pretty convincingly shows that you can use an oral step down in the setting of osteomyelitis, so that it would certainly be appropriate if you have organisms that are susceptible to oral agents to treat them with oral agents after an IV induction. So let me stop there. Thank you again for your time and for your attention.
Thank you very much to our faculty, and thank you for our listeners for joining in. Please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.